All right. Well, hello and welcome everyone to phase 2 of our TCAN advocacy campaign, Together in Care, where we hope to empower neonatal teams in palliative care. My name is Dr. Manicum. I'm a NICU fellow at LA General and Children's Hospital, Los Angeles, and I'll be moderating today's session. So before I introduce our speaker today, Dr. Leuthner, if you could advance to the next slide. Perfect, thank you. Here's information on our next webinar, Pearls from a Palliative Care Physician for the NICU Provider, with Dr. Jennifer Linebarger. It will be on June 10th at 2 p.m. Eastern, and you can use these QR codes here to register, and we'll show these again at the very end. With that, today we are fortunate to have Dr. Leuthner speak to us about the pragmatics of developing and carrying out a perinatal palliative care birth plan. One second. Dr. Leuthner, I had your bio up for a second. Dr. Leuthner received his MD from the University of Chicago and Master's in Healthcare Ethics at Loyola University of Chicago. He completed his pediatric residency and neonatology fellowship training at Northwestern University in Chicago as well, during which he completed graduate work in bioethics. He currently is a professor of pediatrics and bioethics at the Medical College of Wisconsin. He practices neonatology, initiated, developed, and continues to have a leadership role in the Fetal Concerns Center, and is the recently appointed medical director of the palliative care program at Children's Wisconsin, as well as serves on the hospital ethics committee. His interests in many publications include issues related to neonatal ethics, such as limits of viability and birth defects, palliative and end-of-life care in neonatology and beyond, and fetal care counseling for prenatal diagnosis of fetal anomalies. He served 6 years on the AAP Committee on Bioethics, 6 years on the section of bioethics, and is currently the chair for the section on bioethics. So with that, Dr. Leuthner, take it away.
All right, thank you. So welcome everybody. Having had the opportunity to review what has been going on with this series so far, I hope to build on the discussions that we've had from the great speakers. And my goal is to share examples of our palliative birth plan and really take you through it from maybe a little more personal way on how I do it and some pearls that I've learned over the days. Because I think in the other talks, you've heard a lot of great communication tools and a very comprehensive overview of things. And so I want to share with you what I think as a neonatologist and have been doing for decades now works. So again, I want to set the stage in the perinatal environment. I want to provide concepts that you can see that will carry throughout the talk here, demonstrate components of a birth plan, and really discuss then having the fortitude to carry out that plan in the delivery room perhaps as well, or NICU. So just to begin quickly to set the tone, obviously most pregnancies are normal, so we have to appreciate what we're doing is the abnormal situation. And so a normal ultrasound is characterized by a lot of joy and celebration. And really, what's happening? Well, some researchers here who I've worked with, and these researchers have published actually using interviewing of our patients we've managed here. Families are transitioning to parenting during a pregnancy. And so I think that's an important concept to understand. And so really what we're doing in my viewpoint is, yes, there's pregnant women and yes, there's a fetus, but what I would suggest is that much of fetal counseling is really informing transitioning parents about what options we can provide for their child to be. And so depending where they're at in that transitioning stage and how they're viewing that child to be, there are different options people often choose in these situations. And that can range from termination And in some ways, I almost discuss this with families as a withdrawing of life-sustaining treatments at some level. They could provide comfort care or withholding life-sustaining interventions, or we could provide some level of limited resuscitation or full interventions. And so really, to help this transitioning parent make a decision for their child, it entails pediatric ethical frameworks in a sense. And as you all have done probably some ethics training, but there's these concepts of best interest. It's probably the most common theory that people put forward always. Oh, what's in the best interest of the neonate or fetus or the woman, perhaps? And then Lainey Ross has her constrained parental autonomy uh, theory, which I think really hits home a lot as you have an intimate family that you're dealing with. And of course, there's the harm principle where we're not going to let parents harm a child. But to me, a very practical framework is this zone of parental discretion. And actually, Dr. Gillum here has won the William Bartholomew Award from our section of bioethics this coming year at the AP meeting. So, but what she kind of frames it in this zone of parental discretion. And the reality is there is always a child's best interest zone, right? We're not going to let a baby in our unit not get blood because parents are Jehovah's Witness. And then there's things that that parents can do that might harm a child, like child abuse, for example. But then you have this zone of parental discretion and this kind of zone of probable harm where I think those are the areas where we have more need of an ethical analysis for cases to try to support parents in their decision making for their child and when we may overstep that or not. Another way to look at it, and this I know was brought up in one of the other talks, is the IPO framework by Dr. Mercurio and Cummings. And again, in the neonatal world, they've described this. There's the obligatory cases where we have to provide services, the 28-weeker, the Down syndrome child, whatever. And then there's the impermissible point of view where perhaps we won't do it and we don't offer it. And then there's the permissible zone. And really, that zone of parental discretion and the permissible zone are really two different ways, I think, of describing the same thing. And so, whichever model seems to help you process these things, I think you should think about using in your work with these cases. So, concepts we're going to be hearing a lot about or I want you to always be thinking about as we're approaching these cases is who is your patient? Is it the mom? Is it the neonate? Is it the fetus? Is it, and where is that balance, right? And there's always a balancing of values. There's balancing of the pregnant woman's values. There's balancing of family values. There's balancing of a fetal and neonatal values. And then there's the idea of offering options and what are reasonable options to offer. And then also this idea of we need to make recommendations to help because we shouldn't just be candy dispenser machines of options, is the phrase I often use. So what are the real scenarios that you as a neonatologist can use palliative care skills? Well, the most commonly one that people think about is the extreme premature infant, perhaps right at the cusp of viability to non-viability. And what are palliative care skills that we're using in that scenario? Then there's what we have historically referred to as the lethal anomaly. And I have the word lethal in quotes because there is some interesting ethical literature and conversations about what does lethality mean. And perhaps lethality, in some cases might be a self-fulfilling prophecy. And of course, yesterday's lethal in some scenarios might be today's viability, right? And so we have to recognize with science advances, maybe that word can change meanings. And then we'll discuss throughout some cases perhaps on when maybe it's okay to use that word and maybe we shouldn't use that word. Of course, I think we often have moved from the fetal world of this baby's going to die anyway to now palliative care being involved in conditions that are life limiting, but where they can live a somewhat lengthy life. And also, it's being used more and more in conditions that could be cured. Again, I put that term in quotes, but are high risk of dying or having complications despite our efforts. For example, the hypoplastic left heart syndrome situation. Or when we're dealing with fetal interventions, if for those of you who work in fetal centers where people are doing interventions, initially fetal interventions were because the fetus is dying if we don't do something. And then they've moved to reducing disability or improving quality of life with things like the MOMS trial and the myelomingocele repair, and with potentially some balloon valvuloplasty or atrial septostomies in utero, where they might reduce disability or might improve quality of life or survivability. So again, whenever we're dealing with these things, there's risks, and that's why maybe palliative care could be involved. When we first started in the decades ago talking about fetal palliative care, a lot of conversation was, well, we shouldn't have conversations about palliative care at birth because we don't know anything. We're uncertain about everything. And so really decision making depends on, I always consider it depending on three different factors. One is the certainty of a diagnosis that we have. And then there's the certainty of the prognosis of the fetus that we might have. And then there are cases where it is really about the meaning of that prognosis. So the prognosis may be a range of things, but is the meaning of that range fall within what the parents think is the best interest of the child, or does it fall within an area that we want to give them the zone of parental discretion? And again, in the prenatal world, you might run into cases where we have diagnostic certainty from a genetic defect, for example, but there might be some heterogeneity, right, in that disease. Or we might have cases where we don't exactly know what the diagnosis is, but we kind of have our gut feelings and prognostications based on organ system structures that this is not a good situation. For instance, you might have a child with anhydramnios, and we're not exactly sure why they have anhydramnios, but we know the lungs probably haven't developed, and this is a tough scenario. And so one of the caveats I want to point out is I don't want us to be hiding behind this veil of uncertainty. When there's true uncertainty, it's important to acknowledge that. And I agree we need to be humble in our certainty about things too, but there are times where we may not exactly know how a baby might respond, but we also might know the different trajectories. And we can support the families by describing what those different trajectories might mean, in order to partly help them gain confidence that if the baby takes this path, and it might be if the fetus takes this path. For example, you got ventriculomegaly. If in the third trimester the head blows up, okay, we know what to do then, but that's what this means prognostically. If that doesn't happen, then we know what to do there. So we can at least leave it more than I don't like to have parents leaving thinking, well, we don't know anything, we just have to wait and see. I think we have to recognize that we know things, and we should be open and honest about what we know and what are the different paths, and help guide families in that way. And so when we think about palliative care in the prenatal world, part of the reason people started doing it decades ago, or because as we were looking at the definition of palliative care, it is about the physical, emotional, social, and spiritual elements, and to enhance quality of life for a child and support the family. And they talk about how many aspects are applicable early in the course. And so we started thinking, well, what about prenatally? And again, the tenets by the World Health Organization, of course, we want to affirm life while accepting death as a normal process. And our goal is not to hasten or postpone death, but to support families. And again, you can apply these palliative care concepts early in the course of an illness and in conjunction with other therapies intended to prolong life. and it begins when an illness is diagnosed. And this is why, for example, I believe we need to bring palliative care concepts to any fetal intervention, for example, because we have a diagnosis. And while the family may be pursuing a fetal intervention that will hopefully be life-saving or hopefully be, improving a quality of life or reducing disability, we also know that it comes with risks of in utero loss or other things. And so we need to bring these areas together in conjunction, is an example. Um, so when we think now of prenatal care counseling, uh, consultation hopefully can occur at a family's pace. Although we have to acknowledge that sometimes there's conflicts with some timeframes. You might have a family in clinic who is at a gestational age where we have to make a decision fast for whether they want to continue the pregnancy or terminate or not, or whether we need to get them delivered sooner than later or not. And so I think that we have to recognize that sometimes that those timeframes happen. And sometimes we have the emergent presentation, and a classic example, of course, is the mom who shows up at 22 or 23 weeks in labor and delivery. And she's going to be delivering in that time, next hour or so. But I would tell you that most of our consults are not under that time frame. But it's important that as you learn the skills and develop your skills over in both of those scenarios, I think they can be similar type skills. We just sometimes are forced to speed things up a little bit. And my experience, most of our clinic palliative care consultations really happen over a few meetings. And I always like to look at my first meeting with the family is really about exploring with the family. Our overarching goal is to build a trusting relationship of a mutual of understanding of what is going on with that fetus, what is the family's values, and those things. And so it's really about bonding and building a trusting relationship, and maybe less about any formalized decision making at that time. And then the second meeting is often about developing a more concrete palliative care plan. Or maybe it's not until the third meeting that we're doing that, depending on the clinical situation and depending on where the family's at their pace. And there we hoped to have already started to build a relationship and understanding parental values and choices. And then as we look at developing a concrete plan, we need to have those values and choices facilitate what we actually recommend we do for the family from a maternal and eventually neonatal care perspective. So let's pretend now you're going to your first meeting, and the first thing I want to say is do your homework. I still can tell you my very first prenatal consult, which I didn't think of it as a palliative care consult, but it really was in some ways, was when one of our first nurses called and said, hey, we got one of our first referrals. It's a really bad cystic hygroma and maybe some mild hydrops and that. And I'm like, great. I'm a few years out of fellowship or something like that. And I'm like, okay, now what's a cystic hygroma again? And how do I look that up? And how do I understand what the outcomes of that are again? Because it's not something maybe I've done prenatal counseling on in my fellowship. And so you need to do your homework. Part of that includes reviewing who has this family already seen, what are the findings they were told about. Typically, families come having heard things from other providers that are going to impact how they are viewing the pregnancy at this time. And it could be positively or unfortunately negatively. I've had many families come, well, I was told my baby wouldn't even make it to now, and they were wrong. It's a very common thing you hear from, a family who has a baby maybe with trisomy 13 or 18 or something like that. Or I'm coming to the hospital because you guys do miracles. We always do our miracle marathon network in the children's hospitals, right? And we set our own pace. So So there could be things that families come with different viewpoints. So we need to try to find out what is known about the family's understanding and any express wishes. And that's using your communications from whoever in your clinic or whatever's organizing this consult. For us, it's our nurse clinicians who are taking the intakes. Where's the family seem to be at with this or understanding. And then, of course, part of doing your homework is touching base with if you're if you're in a multidisciplinary clinic, depending on your processes, things can be different. But what did the ultrasound here show? What did people say? What is the family saying about the ultrasound here and things like that? Um, I will say that many families come knowing what they want already. They may know some of the medical data and expectations of the diagnosis. I think it's important to know if they know the sex and to know if we know if the baby has a name, because that way you can personalize the consultation. And then I think it's important to have a flexible agenda. I think we need to have an agenda, but I think it has to be a little flexible. And you need to think about what must the family and you leave that meeting with. And I think, our goal should be the family as an understanding of what are the medical implications of everything and what are the maternal medical as well as fetal medical implications. And then what do I now know about that family from their values perspective? What have I learned? Which means I should have spent some time listening as I did this consult. So again, when meeting the pregnant person or family, introduce yourself and the team. Again, refer to the fetus by name if it's given. Um, these are just some phrases that I not uncommonly start with. Um, I often ask them to tell their journey and tell their story and then tell me more and tell me more and tell me more. Um, you know, and again, sometimes you have a family that says, well, we have a baby with this and we know everything, and you're like, okay, that doesn't help me. Right. So again, it's a matter of developing that trusting relationship that you can have a good conversation. Um, I'm hearing you say is a great way to kind of repeat things to just make sure you're clear. And then, you can always say, I wish is a great tool to use if things aren't, if we're not thinking things are going to go as well as maybe the family is. So we do sometimes need to correct some medical misunderstandings, but we may not. Uh, we may be the first to give bad news, although probably not. And we need to share understanding and expectations. um, and we need to introduce how at the next meeting, maybe we then can develop an individualized plan. But part of that is because in my mind, when I'm doing these consults, I'm already kind of working my way through that plan for that family. We just haven't made it concrete yet, but it's a way to take them through it. Uh, I think Dr. Cortez showed this slide about remapping, which is about reframing, medical understanding and prognostic awareness, expect emotions, map out value systems for the family by asking about their faith and their spirituality or religion or not. And I feel like more and more people aren't, but there are people who are. Most people have some level of spirituality. And then align value, reflect about what you're hearing about their values and hopes. And then eventually we want to be proposing a plan based on that. And that's an important factor. That's where we are recommending, not just offering. So again, the second meeting, let's say we're in a second meeting, or maybe you only got one meeting and you're still moving forward. But often if there's a second meeting, again, you got to do your homework. What has changed at all during the pregnancy or not? From a maternal health perspective, from the fetal health perspective. It's not uncommon. We hear every time we come to the doctor, we find out something new, and that's very distressing for families. And sometimes we have to discuss how after birth we may find more new things because ultrasounds can't pick up everything. Um, it's important to ask how they were doing and try to get a feel for your how did they take in your last conversation? Have they been thinking about those things? Have they discussed them? And you will, I mean, I routinely find a variety of things. You have families who've really thought about it a lot and are very good at expressing what they've thought. They may share how, as a couple or not, they're on the same page, and sometimes they'll share how they're not on the same page, and that's okay. And some have said, we really didn't talk about it. It's just too hard. We don't talk about it. Um, so again, after hearing a little bit more of that, we need to help reassess goals and understanding. And usually at some point in time during the meeting with the family, whether it's the first or this visit or third visit, whatever, I want to bring a draft copy of our palliative birth plan and help walk them through it. And I think when you walk through something on a piece of paper, it becomes real to the family. It's a little more concrete. It's not as much, tell me about your goals and tell me about your values, which, you know, let's face it, sometimes we turn to families and say, tell me about your values. And they're like, what? What's a value? So we have to appreciate, we have to have ways of addressing these things. And sometimes the birth plan helps make it a little more concrete. Um, so really look at it as a tool to assist with communication and advocacy. Um, and there's going to be things on this tool and piece of paper that you may develop at your institution that are going to be useful for one case and not for another. So you fine tune it for each given individual patient. I think creating a birth plan gives parents a sense of control because they feel like they now have something written on paper. People know what I'm going to want. I was able to share that. It helped me solidify what I'm thinking. Um, and I think it can be used to help explore those values and their hopes and worries so that we can be goal concordant in our recommendations. So the next number of slides are just pieces of our version. We basically have a Word document. We bring it in. We walk through this with the families, and we make adjustments and changes as needed. The beginning part, this first page is a lot of the beginning stuff's just the names and diagnoses and who's part of your team. And then the second part is a little bit more of an OB plan, so we can have the dates of due dates or induction dates or C-section dates or whatever, and have an ability for maybe a lot of this stuff will say this you need to talk about with your OB in our clinic, and we can do that. But here's things you can think about. And part of it's to think about how you want to be at the time of delivery as far as all these meds and what you might want. From a labor and delivery perspective, so again, stepping back, a lot of times in the meetings we're talking, we are often seeing families where one of the risks is an in utero demise. So we have to acknowledge that that's a possibility. It may not be high, but it's real. And then there's a risk of stillbirth in some of these situations if they were during a vaginal delivery. Again, high, but not 100%. And I do think it's valuable the more we learn empirically. If we get any numbers on these things, we have to share them. For example, I meet many families with trisomy 13 or 18 who the OBs have, told them all these babies die in utero. They never get to term. They all die, whatever, in utero, which is just not true. They have a higher risk of some in utero demise than a normal pregnancy, but it's actually not that high. And then it's like, well, they all die during the birthing process. Actually, not true. We actually have some data published that says, with a normal vaginal delivery, there are some who die during the delivery process, but at least 50% or more can survive a natural vaginal delivery process. Because some families will come saying, I want a C-section because I want my baby born alive. And we may be asking them, well, why? Because, well, they said the baby's chance of dying is high inside. I one time had a mom who had a baby with gastroschisis who said to me, I'm thinking I want to terminate because if my baby dies inside me, I don't think I can handle that. And I'm like, well, what do you mean by baby dying inside you? Well, the doctor said my baby has a high chance of stillbirth in the last trimester. And I said, oh, what do you think he meant by high risk? And she said 90%. And I said, it's about 10%. And she said, that's not high. I'm like, it is to him, but not to you. Right. So numbers can help and matter sometimes for families to recognize where things fall when we say high risk. Um, but this is the process where we then talk about a little bit of the obstetrical planning. Now, again, we're doing this after we've assessed what our overall goal is for the pregnancy and everything else. But you know, if in the scenario of the family saying, I want every chance of my baby being born alive and I want you to do everything for my baby, some of this stuff doesn't come into play. If it's more of a pure comfort care path, some of this stuff will come into play. And then it's really about, and we'll get into a little more of those things. But it has some labor and delivery stuff, some resuscitation status, which again, we fine tune per baby and parent conversations. Some medical things we're going to definitely do for the baby if we're doing comfort care in particular. And most of this is for those who families are doing comfort care, is we're using this plan. And so I'll get into things a little more depth here. And then we talk about keepsakes. We talk about feeding or not. We talk about other subspecialists, spiritual support, and then some after birth diagnostic issues, depending what's been done prenatally. Do we want an autopsy or not? Do we need genetic testing or not? Do they have a funeral home or not? What is this a child who could maybe go home with hospice or not? What about newborn? Do you want all these shots or would you rather not have pokes? So these are things that on our care plan that we have that help us concretely in the family make decisions individually for their child. So in the development of that plan, we looked at these components, right, of advanced care planning. And a big one's the environment and site of care, the care of the pregnant patient, the care of the newborn, the family-centered concepts, spiritual, and then after death issues. When we talk about where, it can vary on the clinical situation and what the family wants. But if it's, for example, a baby with anencephaly and a family is recognizing they just want comfort care and their primary OB is at a community hospital and they have a great relationship with them and they have a pediatrician for their other kids who we can work with, we could develop a perinatal palliative care plan with those providers and have them do it in the community hospital because really that's providing primary perinatal palliative care that you hope any pediatrician could help an OB can help support a family through. Now that's very different than someone who has another, multiple birth defects and the family wants an evaluation in a NICU, but they're not sure how far they want to go and they don't want to cause suffering, but they want to try things. So now you're working your way up to secondary and tertiary sites. And I know Dr. Cortez had a slide in there about these components as well. And so I think that's important to think about as you're working with these families are where are they capable of getting the right environment of care? And when I say environment, location isn't as important as mindset or the people present. And it's about the attitude of staff and the desire to be present for those families. If you're going to be delivering at a community hospital that's going to be judging a family because they're not doing some neonatal intervention, that's not the best place for them to deliver because they're going to be judged and abandoned and be told they're giving up and all these other things, and they're going to cause more harm. So I think it's important to understand what everybody's willing to support at the different environments. And so again, the prenatal discussion might include possibilities of community delivery, academic, your home hospital, and then also maybe the possibility of going home from there if the baby would survive. I always tell families, I know what I can promise we do here. And if there's a community hospital they're going to deliver at that I know the people there, I can promise some stuff there. But, we have to see where things go. I think it's really important, and I think we need to be, on one hand, be careful we don't overstep our bounds about obstetrical decision making, but on the other hand, appreciate that we have some knowledge and we have to be consistent in what we're recommending obstetrically and neonatally. And part of that stems from first assessing the goals for the family to help determine that plan. Um, we, I think it's important to always provide whatever would be the lowest risk for the mother and for future pregnancies. Um, for many families, they want to avoid a stillbirth. But for some families, that wouldn't be the worst thing, right? So we need to assess this from their perspective. Um, and then we need to talk about aggressive obstetrical monitoring or not. I would say that for the typical comfort care cases that we deal with where the family might want a live birth, but we talk about balancing risk to mom, because for example, if we know it's an anencephalic baby, family's accepting of it, we're not going to do any aggressive care, the baby's going to die at some time frame. And she's a 24-year-old G2P1, wants more kids. And we're going to say, I want a C-section to guarantee that baby's born alive. Does mom understand that that C-section, while usually pretty safe, the risk of complications actually percentage-wise is no different between elective C-section and vaginal delivery. It's just they're qualitatively different with surgeries. But probably the percent number of complications isn't that much different. Um, but but then she has these future risks, right? You got a uterine scar now. You could have a placenta accreta. You could have a ruptured uterus for the next pregnancy, and all of a sudden you got an HIE baby on your hands. So those are very low risk, really very low risk, but they're still higher than the chance this other baby will survive. And so when we talk to families about that, I actually have them image a scale like this, and I say, you're the one who has to tell me whether that future risk is a 1 pound weight, a 10 pound weight, or a 100 pound weight on this scale. And whether being born alive is a 1 pound, 10 pound, 100 pound weight in order to try to help. And I feel like that's a model that I've seen people in their head recognize and helps them make their decision. And so again, while a risk of stillbirth for an anencephalic might be high, it's most are still born alive, and many still are born alive, and we don't have to do fetal monitoring. So many times if the family has acknowledged they don't want a section, it's like, well, then we don't recommend continuous fetal monitoring because then there will be team and everybody wants to respond. We could do spot monitoring. Do you want to know if the baby's born alive or not? Once the baby's born alive, we'll put in your arms. Um, and if a goal of a family is born alive, a lot of times we can, say, hey, I think I saw the cord pulse, and according to, the born alive law, that means the kid's born alive, and then I'll pronounce them in an hour. Like they die when we pronounce them. So I think, those are balancing acts one can make to help try to justify and help a family in their grieving process through this. But again, we need to be consistent in these obstetrical and neonatal plans. Um, if the family wants full neonatal resuscitation and wants their baby to go to the NICU, well, then we probably need fetal monitoring and those things. But again, if I'm thinking, despite my efforts, it's not going to work, I'm willing to accept that, hey, don't monitor. And if the baby's born depressed, we'll start a resuscitation, but let's talk about where we draw the lines. And again, delivery options are listed here that I think we need to all be open to supporting families in any of these delivery options. So from a care of the newborn, then, we need to address parameters of treatment initiation, evaluation, and potential withdrawal. Um, and that means in the delivery room, but also potentially in the NICU, it's not bad to start to have some of those conversations. So again, you might have a family who acknowledges that in their mind, this is not a baby who they would want, if the baby even could survive that quality of life, or we're saying the baby likely won't survive despite our efforts, so we don't think we should do things. They might say comfort care from the start, and we can support them in that. Some families say, well, I want you to just do an assessment and be sure after birth and whatever. And we talk about how about if we do normal transitional support? It might help you offer some time. We can do some stimulation, some bag and mask ventilation, but we're not going to go full aggressive, putting breathing tubes in, chest compressions, and those things. And then there's families who want more aggressive resuscitation. A common example where we're really negotiating these things might be someone who, again, had fetal oligo or anhydramnios, and we're worried that they might or may not need dialysis, or the kidneys have failed and we know they're going to need dialysis. And if the lungs are really bad and they need dialysis, the likelihood of survival is very low. And so we may offer families, after negotiations and evaluations with them about their values, of we're going to put a breathing tube in, we're going to see if the lungs are developed reasonably well enough to maybe get us to someday dialysis. Maybe if we're blowing pneumothoraces in the delivery room, we're going to say we're going to stop there. If we don't blow pneumothoraces in the delivery room, great. We'll bring your baby to the NICU and we'll get a blood gas and we'll see where the lung volumes are by gas and things like that. So again, these are things that I think are very good to be open about and share with families and help draw some limits, based on what you're hearing their values are. But it's okay to say, you don't want your kid to suffer. I'm hearing you say you want me to try. I'm willing to try. I don't think it's going to work, but I'm willing to try. And if I'm blowing pneumothorax, I don't want to cause harm to your baby, and see what the family says. And most of the time they won't dissent to that. And I think that offers them that support they needed to be able to walk away without regrets. So I think it's important to, if you're going to be resuscitating it, it can be stepwise. It doesn't have to be all or none. Now, and that stepwise should not be stupid stepwise. I do see altered codes all the time in the palliative care world, about how they want this, but they don't want that, and that doesn't make sense based on NRP. You don't do that, but and then drawing limits in the NICU. An example here might be the a diaphragmatic hernia we're very concerned about. Perhaps this family, after consultation, has said, if my baby needs ECMO, I would rather not do ECMO. Okay, so we can draw some lines in the sand. It doesn't mean in the NICU we're not going to re-engage and ask if things happen. But while you are in a quiet state of mind thinking about what you want and what's best for your child, that's a better time to make plans than it is in the emergent situation. You want me to put your baby on ECMO or not? If I don't, they're going to die now. That's not fair to families in a sense if we have time to plan ahead. Sometimes we don't, but if we do, we should. These are just some questions that might be going through a parent's mind. And you could see the range of options here, and some of them pertain to the family, some about the baby, and some just anticipatory guidance. And so when we're talking about care of the newborn, we can do some prenatal anticipatory guidance. How do we imagine this baby will die, and what might that look like? We should avoid predicting exact time to death, celebrate whatever time. We talk with families a lot about, let's celebrate the time we have. share a reasonable time frame, share the psychological struggle for a parent who, once they're holding their baby and they're not dying as quick as they thought, and then they're wishing they would die, and then they're feeling terrible. Why do they wish their kid would die, and whatever. I always try to validate with families that these struggles are normal. Um, and then develop your pain and symptom management. And again, ours is basically morphine and Ativan are the most common things. Um, so facilitate human contact and warmth is a very common feeling we all have. I will say there was a Lancet article once in the past about a stillborn about a surveying and reviewing families who had babies that were stillborn. And some of them said the families who didn't see or hold their baby were doing better than those that held their baby. So I think if there's a family who doesn't want to do these things, we have to respect that. And we also you will run into families who one of the parents wants to do it and one doesn't. And then I will tell you the most likely scenario is when the day comes, both are doing it, right? I mean, and that's okay. Just validate that whatever they want to do is normal and they don't both have to do the same thing, and that's all okay. Um, so facilitate presence, always inquire about spiritual support, um, and then talk to the family about some agonal breathing, apnea, the hiccuping that restarts some breathing sometimes in these babies, and then they slow again, and talk about those things. Also, tell them that the baby doesn't get, rigor mortis and stiff and start smelling right away, because some families have that idea. We have to acknowledge we don't explicitly understand the fetal neonatal mind. Um, we probably want to err on the side there's pain, yes, there's might be hunger, there might be suffering, depending on the clinical situation. And so we do want to ask the parents what they perceive as this. And so part of palliative care involves informing, educating, and supporting families of the dying individual. And so the issue is always about doing something or not doing something in these scenarios. And the reality is, most clinical events that cause parents and providers distress are the reflexive breathing things. Most of the time, the patients are obtunded, and we probably don't need to give medicines. And generally, we can reassure people in the delivery room that that's the case. But if people are really uncomfortable, that if the baby may be uncomfortable, giving a sublingual dose of morphine or a buccal dose of morphine isn't going to hurt. It's not going to hasten the death. You're giving a dose that's like 0.15 per kilo buccal. It takes 15 minutes to get in anyway, and it's not going to stop the baby from breathing. So if that's the situation, you could always do it. As far as providing oxygen for comfort, um, it probably doesn't make the patient feel better. It might make a parent or clinician feel better because we're doing something, but it might also lead to prolonging the dying process. So it probably should only be justified if we know it confers comfort by relieving dyspnea, which is pretty rare in the newborn baby born and dying in the delivery room, that they have that issue. If morphine's a better drug, if there's any concerns of discomfort, if the family wants the life extended a little bit through non-invasive means, you could do it, I think, and that's reasonable. And there's an article we wrote here about who are we comforting, and we have to acknowledge in these situations we're comforting sometimes families and ourselves maybe more than the baby. I'm going to skip this for the moment, because I want to highlight, this concept of to do something versus to be with somebody. And our instincts as humans, as parents, as physicians, is to do something. But when dying is anticipated, and the inclination to do should be replaced with the side of our humanity, which is to be with. And like the very words that we speak, appearances matter. So being with rather than doing to or for is so important. And learning to be comfortable in that being with, learning to know it's okay to be silent, even. And, you don't need to worry about saying something that's going to make it better because you can't. So you just say you're sorry, or you just tell them how loving they are as parents and things like that. Um, and it's this concept of bearing witness. And a family talked about how it was the only time their doctor made them feel not rushed and everything. There's a term in the nursing literature called being with, and through this concept of guided participation that I've worked with these folks with and written about. So very useful thoughts about just guiding families and being with them. You will be in the delivery room of a baby who isn't turning a corner, who is dying despite your efforts, and the family might be crying and saying, do something, and you just have to be with them and say, I'm sorry, it's not working. And as we talked about, we don't want your baby to suffer, and we're here to support your baby and comfort them, and just be with them, and have the wherewithal to just be present and not say, sorry, it's not working, and leave the room. Um, so I'll, this is some more being with competencies that you guys can get in the slides, but be present. Don't just walk out. When you were talking about family-centered care, it's important to be sensitive, obviously, to different culture and ethnic and religious beliefs, and empower the family with choices. Um, Encourage sibling involvement as developmentally appropriate. One of the common things we run into as parent wants to protect the other kids from this baby's death. And I think we need to help support the families in doing those, and bringing the siblings in, because there is evidence that siblings who are included in care, taking care during these illnesses, are prepared to present at the time of death, participate in the family rituals, and supported by family and grief work, are demonstrate much higher self concepts and psychological growth over time as young adults. And of course, legacy building is something that we do a lot of in most NICUs. I think now this is standard. It actually started through RTS, which is Resolve Through Sharing, which is a nursing program that started in OB for stillbirths. So really, a lot of our NICU memory making stemmed from the world of OB stillbirths legacy making. And there's so many different things people do now. From a religious perspective, I just think it's important to always offer personal pastor support if they want, helping, discussing that this is a good time if you want to plan memorials or cremations or burials. You can do some of that ahead of time if you want. You don't have to do it ahead of time. It gives some family, the dads, sometimes something to do, to be honest. But this is a little embarrassing to admit, but everything that happens for no real reason. And again, spirituality is about making meaning of the event. Virtually every family when we counseled families, found comfort through their beliefs in God. Some reported returning to religion to fill that void. We didn't see a lot of people angry and turning away from God, to be honest. And so many people spoke how their spirituality helped them. So it's a very important thing to be open with and support and address. And then the after death issues. Again, now with more and more prenatal genetic testing and all this other stuff, depending where you're at in the country, people do more of it or less of it. But it's important to work with your geneticists, genetic counselors, to see is there something we can do after? So regarding autopsy, when people have looked at autopsies of like even stillbirths or infant deaths, 10 to 40% of the time it added some new information. So sometimes it just is valuable in confirming. It might help with future planning. It helps with grief support and alleviate guilt. If the plan was to try resuscitating because the lungs are small, and if it doesn't work, let the baby go. And then we get an autopsy, and in that autopsy, we can meet with the family and say, yeah, the lungs were so tiny, it wasn't going to work. It just validates things. And then I'm assuming maybe you guys will have another thing more on bereavement, but I know we have a bereavement coordinator that we always work with our hook up our families with, um, which do follow-up phone calls and cards and all these other things and help with community supports. So when we asked families what helped you cope with these things, it was their family support. It was keeping the memory alive. I always tell families that are couples that, hey, when you go on from this, um, grandma and grandpa or sister and brother and other people may not want to talk about your baby because they don't want to make you cry or sad. And if you want to talk about your baby, you tell them you want to talk about your baby and you got to advocate for yourself. And again, if they're talking about your baby all the time and you don't want to, tell them to shut up too. But so I always support families in saying this is going to be a very important thing for you, and I always coach them on how to use their families for their supports. Um, and in the end, again, this is all about navigating relationships. And Dr. Cote Arsenal, again, came up with this diagram after doing a lot of interviews of a lot of our patients that we've taken care of through the years, and looked at the stepwise fashion of comprehending implications of the condition, revising goals of pregnancy, making the most of time with the baby, preparing for birth and inevitable death sometimes, advocating for baby with integrity, and adjusting to life in the absence, and with the overarching goal of no regrets. We don't want, that's really an overarching goal. We don't want these families walking away from these situations having regrets. And just some resources, and I believe I'm done. And just